Good afternoon, and thanks for joining us for today's Healthline 3. I'm Courtney Butts, and Healthline 3 is a conversation where we like to focus on ways to help you live a healthier, happier, and pain-free life. And joining us for today's conversation is Dr. Chris Caldwell, orthopedic surgeon with Willis Knight and Piermont Orthopedics. Thanks for joining us.
Yeah, thanks for having me.
Absolutely. So orthopedic surgeon, what's your primary focus with orthopedics?
So I do hip and knee replacements and then revision hip and knee replacements.
Gotcha. Cool. So how long have you been practicing here in Shreveport and with Willis Knight?
Well, I've been in Shreveport this is my 6th year in Shreveport, but I came down to Shreveport for my training at LSU Shreveport, and I met my wife down here, and so finished up my training, did a year of fellowship in hip and knee replacements, and that was in Austin, Texas, and then Shreveport just felt like a natural place to come back and start practice.
Well, we're happy that you stayed, or you decided to stay. Where are you originally from?
I'm from right outside Charlotte, North Carolina.
Nice. Okay, so still in the South somewhat.
Yeah.
Yeah.
Tell my wife that Charlotte's in the South.
Yeah. So I mean, and so have you liked the culture and everything here in Louisiana? Yeah.
Yeah, it's awesome. I actually went duck hunting down in South Louisiana for the first time this past weekend.
Oh, fun.
Yeah.
That's awesome. So why orthopedics? What was it that drew you into the specialty?
So my road to orthopedics started really early. I actually knew that I wanted to be a hip and knee surgeon whenever I was a senior in high school. When I was in high school, my dad, who was a former college baseball player and All-American, he was very active in my life. We'd go out and play catch or play golf, and one day he just woke up and he had severe hip pain, and it turns out that he needed a hip replacement. So we took him to our local orthopedic surgeon. He had a hip replacement, and he went from almost not being able to walk to back to my normal dad. I mean, he got his life back, I got my dad back, and so as I was getting into college and starting to think about what I wanted to, what direction I wanted my life to go, I started shadowing the surgeon that operated on my dad, and when I saw what he did, things just clicked, and I've been in love with it ever since.
I love that. What a cool story too, and very personal, and it's also, I'm sure, what I've heard, in this specialty is that the results after the surgery, that rewarding feeling of like you feel like you probably changed somebody's life.
It's amazing. I mean, like I said about my dad, I mean, you give people their lives back.
Yeah.
Some of these patients that come in, I've been talking to them, and they've had debilitating hip or knee pain, and they've been walking with a cane or a walker, and previously they had a very active life. They were able to do stuff in their backyard, or they'd go hunting, and they've had to delay that for years, and then they do get a hip or knee replacement, and they get all that back.
Yeah. Yeah, right. So my mom actually, she's pretty young, I would say, considering that, what would you say, first of all, is the median age that you operate on, if you could guess? Yeah,
so I think there are some exceptions, but most of the hip and knee replacements are patients older than 40.
Okay.
And usually older than 50.
Okay.
But it just depends on how severe their issue is with their hip or their knee.
Right. My mom is almost 50, and she has been having hip pain for years now, since she was in her mid-30s. And so come to find out, she has hip dysplasia, and she didn't know, something that could have been fixed at birth.
Right.
But is that something that you commonly see and maybe operate on for a hip replacement?
Yeah, so that is one of the kind of not as common reasons for a hip replacement, but definitely something that we see a fair amount, and that's a condition that is made a ton better by a hip replacement.
Yeah, right. So yeah, she's looking forward to that whenever that time comes. But so before even getting to surgery, some people maybe are really nervous or apprehensive about surgery, but maybe they are in a lot of pain. So what options do you have for those patients? I'm sure you have a lot of those patients in your clinic. Yeah,
so the most common cause for hip or knee pain in the patient population that I see, patients over 40 with hip or knee pain, is osteoarthritis, which is a wear and tear arthritis. And so basically what happens in that is the cartilage in your joint over time kind of wears away. along with kind of the other soft tissue buffers, so in the knee, the meniscus, and the hip, the labrum. That all kind of starts to wear away, and it becomes bone on bone. And so there are a lot of non-operative treatments that are really successful for hip and knee arthritis. We start everybody out with anti-inflammatory medications if they can take them, like ibuprofen, Tylenol, meloxicam, things like that. Bracing helps sometimes for knees. Also, activity modifications. If you do something that you know is going to hurt your hip or your knee, either avoid doing that or do it only occasionally and then rest for the rest of the day. Icing, stuff like that. You can try home exercise and physical therapy to try to strengthen the muscles around your joint that's hurting you. And then occasionally we'll do injections, especially in knees, and that can give people relief sometimes for months or even years.
Nice.
But like I tell my patients, you know, all of those are treating the symptoms of arthritis, and those are not treatments that are going to regrow the cartilage. They're not going to reproduce the joint space that they lost with the arthritis. And so eventually the non-operative treatments stop working, and it could be months and it could be years from when we first start treating the patients. And at that point, that's when we start talking about surgical options.
Right. Okay. And so, you know, typical, so the hip dysplasia is not as common that you see in your practice, but
Right.
the osteoarthritis is probably the major factor.
Yes.
Right.
Yeah.
Okay. Any other things or symptoms that or I guess reasons why they need hip or knee replacements?
Yeah, so for anybody that has previous trauma around
Okay.
a joint, that would be a common cause of needing a joint replacement. So if you ever hear about athletes that blow out their knee or they have ACL injury, there's a higher rate of knee replacements later in their life, not right away. We're talking about 20, 30 years down the line. Or people that have fractures, sometimes the way to treat a fracture is to do a replacement, especially around a hip.
Okay. And a lot of this, you're able to determine this through like workups, like x-rays, and what other diagnostic tools do you use to determine, you know, what's going on with their hip and what is the cause of the pain?
Yeah, so by far the best workup is an x-ray. We can tell a ton from an x-ray. Occasionally we'll order a CT scan or an MRI to kind of get some more information that x-rays don't give us, but the x-rays usually tell us all we need to know.
Yeah, what does the arthritis look like on an x-ray?
I always kind of like to compare a normal joint for patients to a joint that has arthritis. So in a normal joint, you can see the bone in an x-ray is white and the soft tissue is black. So the x-ray doesn't pick up soft tissue. And so in a normal x-ray, you see a nice black space between the two bones. And in arthritis, that space is either narrowed or completely gone, and it's just white on white.
Yeah, and that can be pretty, like for your dad, it was very painful.
Yeah, absolutely. It can be completely debilitating for patients.
Right. Okay. So for those that, you know, maybe they know they have osteoarthritis, but they don't really, you know, arthritis is a word that we use a lot because it's so common.
Yeah.
But what actually is it and what's happening when you have arthritis?
Yeah, so osteoarthritis is wear and tear arthritis. That's different from rheumatoid arthritis, which is kind of an autoimmune situation where your body attacks the cartilage and soft tissue cells around the joint. So osteoarthritis is the most common, and that's wear and tear arthritis. So in a normal joint, the way that it moves smoothly is there's cartilage on both sides of the joint. And over time, as we age, and especially if you live a very active life, you are kind of doing stuff that kind of wears on your joints, that cartilage starts to wear away. And under the cartilage is bone. So if you ever hear people say that they have bone-on-bone arthritis, that's kind of the same thing as osteoarthritis.
Gotcha. Makes sense. Okay. So if you're just joining us and you have a question for Dr. Caldwell, you can give us a call. That number is right there on your screen. It's 318-219-4569. He is an orthopedic surgeon, so we are talking specifically about hip and knee replacements. So please narrow your focus and your questions to that topic. But again, that number is right there on your screen, and we're happy to answer any questions that you have. So with hip and knee surgery, when do you start having those conversations with patients? Like, what are those symptoms that maybe people are, at home wondering, when should I have that conversation with my doctor?
Yeah, so whenever I see a patient that has hip or knee arthritis, we start them into the non-operative treatments, which we talked about. But I always tell them they're not going to make anything worse by waiting on surgery. So it may be that for them it takes them several years in order to exhaust all of the non-operative treatment and get to the point where they want to start talking about surgery. Other people, they're ready right away. But I always tell them that they're the ones that are living in their body. They're the ones that are experiencing the pain. Whenever the pain is not worth living with on a daily basis, then that's when you need to start talking about surgery.
Yeah, so that quality of life.
Right. Exactly.
Okay, so you do hip and knees both. What would you say is more common in your practice? Are they pretty 50-50?
Yeah, it's probably a pretty even split, 50-50.
Okay.
Yeah.
And just because you have a hip replacement, does it mean that you'll need a knee replacement?
Yeah. Just they're all kind of independent joints. So just because your right side wears out doesn't mean that your left side's going to wear out either.
Okay.
So.
Interesting. So can you tell, before we get into like the ins and outs of the surgery, can you explain like the joints of a hip and a knee and why maybe it's so common to have them replaced? I guess because of overuse or? Yeah.
So overuse is definitely one of the main reasons. So a hip is a ball and socket joint. So there's a cup and a ball, and those articulate, and the round head moves smoothly within the cup. The hip joint carries all of our weight that we, whenever every step that we take for our entire life goes through our hip joints and through our knee joints. The knee joint is more of a hinge type of joint. So you have several areas in your knee, on the inside and the outside, and then where your kneecap moves smoothly on your knee. So in any of those three compartments, is what we call them, you can have arthritis.
Oh, okay. Yeah. So, and when you're trying to decide on surgery, is there certain methods that you use for hip and knee, or is it pretty standard each procedure? Does that make sense? Yeah.
So there's several different approaches for hip replacements that that surgeons use throughout the nation. I like to specialize in anterior hip surgery, especially for a first-time primary total hip. I think that patients recover a little bit easier from that surgery. And so that's kind of going through the front part of the hip. We can move muscles out of the way instead of having to cut through muscles and tendons. And so that's why the recovery is a little bit easier.
Right. Very interesting. Yeah. And that's kind of a newer, is that like a newer approach within the last, I don't know, 10, 15 years or?
Yeah, I think it's got some traction over the last 15 years or so, and it's kind of newer, but definitely a proven approach at this point to treat arthritis.
Like you said, the recovery, just thinking about having to recover from a cut bone or a cut muscle, and then just having to recover from that, and I'm sure that that's a much more difficult recovery, whereas when you're just kind of moving some things around and doing what you need to do.
Right.
Yeah.
So the field of orthopedics and the field of hip and knee replacements has come a long way in the last 20 years. So 20 years ago, whenever we would do a hip or knee replacement, patients would stay in the hospital 3, 4, or 5 days, sometimes up to a week. And then they would almost always go to a rehab facility. It was a very drawn out process. And we've learned more as surgeons about how to control patients' pain by doing different techniques with the way that we handle their muscles and their tendons. But also we've learned about the anesthesia, on how to take care of patients around surgery, and the pain medication that we can give them afterwards. And so, kind of like we talked about earlier, now the majority of our patients are able to go home on the same day of surgery.
Yeah, that's pretty incredible. Cool. So we do have our first caller. Rita, thanks for joining us. And what's your question for Dr. Caldwell?
It might have already been asked, but I want to know, can anything be put in between the bone on bone? knee.
Yes, ma'am, absolutely. So, you know, whenever we start treating people that have bone-on-bone knee arthritis, we always talk about non-operative treatment first. But if you get to the point where you need surgery, then the surgery that puts things between the bone-on-bone of your knee is a knee replacement. So they've looked at putting other things through a scope, and that's really not been very successful in patients or very reliable. And so the best way to recover from that from a surgical standpoint is to do a knee replacement.
Okay, thank you.
Yes, ma'am.
Yeah, thanks for calling us, Rita. And if you have a question for Dr. Caldwell, you can give us a call. That number is 318-219-4569. So you mentioned something earlier, like a total knee replacement. Is there ever like a partial knee replacement, and when is that indicated?
Yeah, so
or hip, whichever one.
so for hips, there's not really a partial hip replacement.
Okay.
Just the way the bone structure works, it's better just to replace the whole thing. The exception is sometimes in fractures with patients that really just can't tolerate a full hip replacement. But in patients that have hip arthritis that are seeking medical care on an outpatient basis, the surgical treatment is a total hip replacement. For knees, there is such a thing as a partial knee replacement that's in pretty select patient populations and usually younger patients.
Gotcha.
So whenever I say younger patients, late 30s, early 40s. Once you get past the mid 40s and definitely into the 50s, it probably just makes more sense to do a full knee replacement because it's a much more reliable procedure.
Mm-hmm. Makes sense. Okay. Do you know the age of your oldest patient that you've ever operated on? Can you recall that, or if you have a guess?
Yeah. So I take care of patients on call too at Willis Knight and Piermont. So anybody that falls and has a fracture. So I mean, I've operated on patients that are in their late 90s or over 100 years old that have injuries. And the reason we operate on those patients is because we know that they would recover from their injury much easier if we operate and stabilize the bones, versus if we don't do that, they're going to be in a large amount of pain. So that's kind of different than somebody that comes to you with hip or knee pain on an outpatient basis and wants an elective surgery.
Right.
From an elective standpoint, I mean, people in their 90s, given that they're in overall good health, tend to do pretty well from surgery. But you know, it's a personal decision.
For sure, yeah. And is there? So I guess the next question would be like, is there an age limit, or is there any restrictions that you have for patients that you maybe wouldn't operate on?
Yeah. So
for safety.
Yeah. So that's a good question. So there's no age limit for joint replacements. It's more of your overall health and how you're going to tolerate the surgery. So there are really healthy 90-year-olds, and there are not as healthy 60-year-olds. And so age is not really a limiting factor in that. Mm-hmm. Then there are some conditions that we would not want to operate on a patient if they've had a lot of infections, if their medical doctors tell them that they're going to be at very high risk for surgery. That's something that we really take a lot of pause, and we try to communicate with the medical doctors and come up with a good plan for treatment for those patients. But sometimes that is only non-operative care. Mm-hmm.
So what about scopes, like knee scopes? Do you do those, and when would that be suggested?
Yeah, so my specialty is replacing knees, and so in patients with arthritis, there have been shown a lot of studies that show that scoping a knee and just doing a cleanup procedure, that was kind of done in the 80s and 90s, and that's really not proven to be beneficial for patients. Mm-hmm. That's different than a sports injury in a 20-year-old who tears their meniscus or their ACL and has to have a knee scope to fix that problem. And so I kind of allow my sports medicine colleagues to do that, and they send me the patients that need the hip and knee replacements that are not scope procedures. Makes
sense. Okay. Yeah, because sometimes, you know, when you hear a knee scope, it's still surgery, right? And I think that may be a misconception sometimes when you hear that jargon, you think, oh, it's just they're checking some things out, but no, it's actually a surgery.
Yeah, yeah, exactly. So a knee scope, you still are under anesthesia. They have 2 smaller incisions, and in knee arthritis, if you go in and you just do kind of a cleanup procedure, it doesn't fix the underlying problem that there's no more cartilage there, and so the patient still continues to have pain even after they've recovered from a procedure like that.
Okay. Okay, so what about the recovery time for, I know it's probably different for hip and knee. What does that typically look like, or when you send patients home, what are your instructions for recovery?
Yeah, so this actually surprises some people. So I tell people that when they come into the hospital, one of the things that helps us with recovery is we do our surgeries mostly under spinal anesthesia now instead of general anesthesia. And so that allows patients to not have to go on a breathing machine and have a tube down their throat during the surgery. And instead it's a similar anesthesia to epidurals that pregnant ladies have whenever they give birth. And so the patients their lower half of their body is asleep during the surgery. Then the anesthesiologist gives them some meds through their IV where they just kind of go off to sleep and they're snoring whenever I'm doing my thing. So nobody's awake. And then afterwards, because they're not under general anesthesia, whenever we wake you up from the surgery, the patients are basically awake right away, and so they can work with physical therapy. They're not really groggy. They're not trying to breathe off all the chemicals from a general anesthetic. The therapists get our patients up on the same day of surgery and have them walk around, and the therapists know what to look for as far as what a patient's going to be safe in order to go home with that level of function. So if the therapists sign off and say that a patient's safe and their pain is controlled, then I have no problem with the patient going home on the same day of surgery. And then, the first 2 weeks after surgery are the hardest as far as recovery. I recommend my patients to have somebody there with them at home that is either living there or checking in on them multiple times a day, helping them with meals, helping them get back and forth to the bathroom and in and out of bed. But every day of those first 2 weeks is better than the last. I see my patients back at 2 weeks to check their incision and see how they're doing, and about half of patients are not walking with a cane or a walker anymore. The other half, we encourage them to get off the walker or the cane within the next week or so. And then the next time I see them back in our clinic is at the 6 week mark, and most of those patients are doing everything that they want to do in their normal life that they did before surgery, like shopping for their own groceries and doing normal things.
And probably feeling much better.
Exactly, yeah. I tell people that at the 6 week mark, they're about 80% recovered. The last 20% takes another 3 to 6 months, and it's a little bit slower to get back all the way to 100%. But normally 80% improvement over what they had before is significant enough that they're feeling 100% better, whenever I see them at 6 weeks.
Yeah, very cool. Love that. I'm sure those 6 week appointments are fun.
Oh yeah, they're really rewarding.
Yeah, cool. I love that. So how long does a typical surgery take for, maybe is it different for knees and hips? Is one more complicated than the other?
Yeah, so it kind of, it doesn't really matter as far as how complicated one is, a hip replacement versus a knee replacement. It's more of how much arthritis somebody has in their hip or their knee. But on average, a knee replacement takes about 45 minutes and a hip replacement takes about an hour. I always tell patients, it takes about an hour to clean up and an hour to set up. So for them, it'll seem more like 3 hours.
Yeah.
But my actual job doing the surgery is a shorter amount of time than that.
Yeah, right. And that's, I'm sure that's a big improvement over the last, like you said, 20 years, and probably a big reason why people can recover, because they're not under the knife for that long.
Absolutely, yeah.
Cool. Okay, so I bet this is a common question that you get, but how long does the hardware that you use last in the body? Yeah,
so that's another way that orthopedics has become more advanced and the technology has improved. So we can now comfortably say that hip and knee replacements will last someone about 25 years as long as everything goes right. And at 25 years, we look at that, and about 10 to 15% of patients have started to wear out their hip or their knee to where we would start talking to them about having to go back and do another surgery, but that still leaves about 85% of people that it still lasts in. So Usually what wears out first is the plastic component. And so in a knee replacement, you have metal that replaces the end of your femur and the top of your tibia, and then there's plastic in between that kind of helps those two parts move smoothly. Same thing in your hip. Inside the cup, there's a little plastic component that allows the ball to move smoothly. And the plastic is usually the first thing that wears out.
Okay, and there are symptoms associated, similar symptoms as before if there was ever an issue?
Right, yeah, exactly. So if you're having a joint replacement that's wearing out, you start having pain or sometimes instability as a result of that.
Okay, and the cool thing is most of this or all of this is done robotically, right?
Yeah. So I offer robotic surgery as part of my practice. I always make sure to tell patients that doesn't mean that the robot's doing the surgery and I'm downstairs having lunch.
Right.
So what a robotic surgery means is we put the surgeon does the surgery like normal, but during the surgery we put sensors on your bones, and there is a computer that's inside the operating room that registers those sensors and some different points that I point out to the computer. And it creates a 3D model that I can look at. And then we can customize a hip or a knee replacement much easier to an individual patient that way. And so we pick implants that we put in a certain position that fits the bones perfectly, and it allows us to do less soft tissue dissection, which allows for better healing and an easier hip or knee replacement for the patient. And then once we get that 3D plan, there's a robotic arm that I guide that helps me do the procedure. And the benefit to that is it locks in exactly what I've programmed. So if your hand accidentally slips, the tools that the robotic arm has on it automatically cut off. And so it's safer for the patients. It protects important structures around the hip or a knee. But it also locks you into the plan that you plan with the robot during the surgery.
Very cool. Yeah, I love that explanation because I think it puts people at ease, and some people, but like you said, it's actually better for the patient and better recovery and all that. So just a couple minutes left, but if somebody is wanting to prevent ever having surgery, what are some, general things that you would suggest? I mean, like weight-bearing exercise, does that help, in the long run, or what other things do you suggest? Yeah,
absolutely. So physical activity, exercise, that's going to be the number one thing to prevent and have healthy joints. Also, maintaining a healthy weight. So the more weight that we carry on our body, the more weight goes through our hips and our knees, and it wears out those joints faster. So I think, routine exercise, eating healthy, maintaining a normal weight, those are the recommendations.
Okay. And do you ever, have patients where you're going to have a surgery, but maybe the weight is something that's holding them back from having that surgery?
Yes, absolutely. So there are weight cutoffs for hip and knee replacements. There's a BMI is a measurement that we use, which is basically a ratio of your weight versus your height. And there have been studies that have shown over millions of patients that higher BMIs than 40 are associated with more complications, the biggest complication being infection.
Gotcha.
So there are patients where we would need to get them to a lower weight before they would have a hip or a knee replacement.
Gotcha. Okay. Are you accepting new patients right now?
Oh, absolutely.
Okay.
Yeah.
How can they contact you? Do they need a referral, or what's the best way to get in touch with you?
They can just call my clinic. I'm over there at the Portico Shopping Center, right behind the Porter's Cleaners, across the street from Wells Knight and Piermont. So.
Okay. Yeah, and I'm sure all of your information is right there on the screen as well. If you wanted to take a picture of that, or it's also on Google, the great trusty Google. Just Google Chris Caldwell, and you'll be able to find, I'm sure, your number, or you could maybe call in and request to be seen by you. So, when's the earliest somebody could be seen? I guess
later this week. I do clinic Monday, Wednesday, and Friday.
All right, there we go. Well, thanks for joining us, Dr. Caldwell. And if you missed this will be on our website. That's ktbs.com/podcast, or also on Spotify.